Tissue Healing and Wound Care, Chapter 6. The phases of tissue repair often overlap each other and can be difficult to understand. The first phase is bleeding. It begins at the onset of injury, and the objective is to stop the bleeding. In this phase, the body activates its emergency repair system, the blood clotting system, and forms a dam to block the drainage. During this process, the platelets come into contact with collagen, resulting in activation and aggregation. An enzyme called thrombin is at the center, and it initiates the formation of a fibrin mesh while strengthens the platelet clumps into a stable clot. Phase 2 is called the defensive or inflammatory phase and focuses on destroying bacteria and removing debris, essentially preparing the wound bed for the growth of new tissue. During phase 2, a type of white blood cell called a neutrophil enters the wound to destroy the bacteria and remove debris. These cells often reach their peak population between 24 and 48 hours after injury, reducing greatly in number after 3 days. As the white blood cells leave, specialized cells called macrophages arrive to continue clearing debris. These cells also secrete growth factors and proteins which attract the immune system cells to the wound and facilitate tissue repair. This phase often lasts 4 to 6 days and is often associated with edema, arrhythmia or reddening of the skin, heat, and pain. Phase 3 is the proliferative phase. Once the wound is cleaned out, the wound enters phase 3, where the focus is to fill and cover the wound. The proliferative phase features 3 distinct stages. First, filling the wound, second, contraction of the wound margin, and third, covering the wound or epithelialization. During the first stage, shiny, deep red granulated tissue fills the wound bed with connective tissue and new blood vessels are formed. During contraction, the wound margin closes and pulls towards the center of the wound. In the third stage, epithelial cells arise from the wound bed or margins and begin to migrate across the bed of the wound in a leapfrog fashion until the wound is covered with epithelium. The proliferative phase often lasts anywhere from 4 to 24 days. Phase 4 is the maturation phase. During maturation, the new tissue slowly gains strength and flexibility. Here, collagen fibers reorganize, the tissue remodels and matures, and there is an overall increase in tensile strength, although the maximum strength is limited to approximately 80% of the pre-injury strength. The maturation phase varies greatly from wound to wound, often lasting anywhere from 21 days to 2 years. The healing process is remarkable and complex. It is also susceptible to interruption due to local and systemic factors including moisture, infection, maceration, age, nutritional status, and body type. When the right healing environment is established, the body works in wondrous ways to heal and replace devitalized tissue. The inflammatory phase, or days 0 through 6. The most common symptoms we see are redness or arrhythmia, local heat, swelling or edema, pain, and loss of function. During the inflammatory phase, we see an immediate vasoconstriction up to about 10 minutes. We also see platelet reaction, including platelet plug or platelet clots. Clotting occurs to decrease the amount of blood loss. The formation of the fibrin clot allows the beginning of wound healing, and then vasodilation helps to bring new blood flow and nutrients to the area. Acute inflammation is a rapid response to an injurious agent that serves to deliver mediators of host defense, such as leukocytes and plasma proteins, to the site of injury. Acute inflammation has 3 major components. Number 1, alterations in vascular caliber that lead to an increase in blood flow. Number 2, structural changes in the microvasculature that permits plasma proteins and leukocytes to leave the circulation. And third, immigration of the leukocytes from the microcirculation, their accumulation in the focus of area of injury, and their activation to eliminate the offending agent. Acute inflammatory reactions can be triggered by a variety of stimuli, including infections and microbial toxins, trauma, physical and chemical agents, tissue necrosis, foreign bodies, and immune reactions. The proliferation phase occurs from days 3 to 21. Angiogenesis, or the development of new blood vessels, fibroplasia, or fibrin tissue formation, and re-epithelialization, or the generation of new epithelial tissue, all occur. The maturation phase can last from a month to a few years. During this phase, decreased fibroblastic activity, return to normal histochemical activity, remodeling of the tissue along the lines of tensile force occur. We may also see the formation of scar tissue during this phase. Depending on how the collagen fibers are laid down, the scar may be very noticeable or very minor, depending on the size, length, shape, and location of the wound. To decrease the appearance of scars, keep them out of the sunlight or rub sunscreen on them when you are out and about. Scar tissue is very tender, much like a baby's skin, and can get sunburnt very easily. When a scar gets sunburnt or even exposed to skin, it will create darker pigmentation to protect the new tissue from the sun, thus increasing the visibility of the scar. Bone healing is a little bit different than soft tissue healing. The healing of a bone fracture follows a series of progressive steps. A fracture hematoma forms. Next, an internal and external calli form, and eventually the cartilage of the calli is replaced by trabecular bone, and then remodeling occurs. Acute inflammation lasts for approximately 4 days. When a bone breaks, blood flow from any vessel torn by the fracture occurs. These vessels could be in the periosteum, osteons, or the medullary cavity. The blood begins to clot, and about 6 to 8 hours after the fracture, the clotting blood has formed a fracture hematoma. The disruption of blood flow to the bone results in death of bone cells around the fracture. During the repair and regeneration phase, it occurs about 48 hours after fracture. Chondrocytes from the endosteum have created an internal callus, the plural of which is calli, by secreting fibrocartilaginous matrix between the ends of the two broken bones, while the periosteal chondrocytes and osteoblasts create an external calli of hyaline cartilage and bone, respectively, around the outside of the break. This stabilizes the fracture. Over the next several weeks, osteoclasts reabsorb the dead bone. Osteogenic cells become active, divide, and differentiate into osteoblasts. The cartilage in the calli is replaced by trabecular bone via endochondrial ossification. Eventually, the internal and external calli unite. Compact bone replaces spongy bone at the outer margins of the fracture, and healing is complete. During the maturation phase, a slight swelling may remain on the outer surface of the bone, but quite often that region undergoes remodeling, and no external evidence of the fracture remains.